Thank you, sir. So may I start with the kind permission of all my esteemed teachers, sir?
Yes, you start.
Thank you so much, sir. Good evening, everyone. Good evening to my respective teachers, my peers here today. I am Dr. Bhaswar Bhattacharya. I am a third year PGT from the Department of Medicine, ITGMR and SSK Hospital, Kolkata. Sir, am I audible, sir?
Yes. Yes.
Okay, sir. With your kind permission, I would like to present a case on quadriparesis today, sir. So to begin with, my case begins with Mrs. X, who is a 42-year-old female patient. She hailed from Burdwan from West Bengal, and she was a homemaker by occupation. So she presented to us with a chief complaint of progressive symmetric weakness of all four limbs with sensory loss for the last 1 month and blurring of vision in the right eye for the last 2 months. Moving on, to describe her symptoms, I am first going to describe the weakness. So the weakness began acutely 1 month back in right upper limb and then involved both the lower limbs and left upper limb within a total span of 48 hours. The weakness progressively increased over 2 weeks and then reached a plateau. And thereafter, the weakness started showing improvement during while in hospital admission. And the weakness was more in the lower limbs than the upper limbs. Also, the patient complains of both difficulty in getting up from squatting position, bending knees, as well as negotiating chappals. And in the upper limbs, she also complained of difficulty in combing hair, as well as buttoning and unbuttoning of garments for last 1 month. And she says that the weakness of limbs was associated with stiffness and paroxysmal involuntary painful spasms. However, she did not complain of any thinning of any muscle groups. Moving on to the sensory symptoms, the weakness was associated with numbness, loss of pain sensation, and insensitivity to heat and cold in all four limbs and trunk from mid-neck level downwards. There was also history of an ill-defined burning neck and trunk pain, which was present for the last 15 days. However, there was no history of any girdle-like sensation over the neck or trunk. She also presented with visual symptoms, and she gave us a history of insidious onset progressive blurring of vision in the right eye for the last 2 months. The blurring had, however, improved slowly over the present course of illness, spontaneously since the last 15 days. There was no history of color desaturation, eye pain, redness of eye, tearing, or itching. And there was no history of double vision at present. She also gave us some bladder and bowel symptoms, which was in the form of increased urinary frequency, urgency, and urge incontinence since the last 1 month. And history of urinary hesitancy and a sense of incomplete evacuation of bladder was also there for same duration. She complained that her bladder senses were impaired, and there was also a coexistent history of constipation for the same duration. Coming to the negative history, she had no history of headache, disorientation, convulsions, or loss of consciousness. No history of drooping of eyelids, facial pain or numbness, vertigo, syncope, vomiting, or any other history suggestive of any other cranial nerve involvement. No history of excessive sleepiness, hiccups, or nausea. No history of abnormal movements of limbs or twitching of limbs. No history of thinning of muscles of the limbs. No history of fever, weight loss, cough, joint pain, rashes, oral ulcers, or dryness of mouth and eyes. And she had no definite evidence of any high-risk fever. It was very much significant in that she had a history of fever, holocranial headache, and binocular double vision, increasing on right lateral gaze 5 months before this present set of symptoms. She was therefore diagnosed as tubercular meningitis from an outside setup and started on anti-tubercular therapy from January 2021, which she was continuing currently, however, with poor compliance. Following which, however, the headache, fever, and double vision had improved. But there was no history of the similar set of symptoms that she had in this current episode in the past. There was no history of hypertension, diabetes, or any thyroid disease. Her family history was somehow insignificant in that she was married for 18 years and lived with her husband and had 2 children. There was no history of similar illness in family members. Her menstrual history was also unremarkable. In her personal history, she was a non-vegetarian with no addictions. Her sleep was disturbed. Her bladder and bowel symptoms has been described previously. And as I said, she had no history of any high-risk behavior. So if I may be allowed to summarize my history.
Yes.
A 42-year-old non-hypertensive, non-diabetic female patient presented with sudden onset symmetric quadriparesis for the last 1 month, progressive for 2 weeks, and then plateauing with subsequent improvement, along with muscle spasms, stiffness, and sensory loss for all modalities in all 4 limbs and trunk from middle of neck for same duration. He also had painless progressive blurring of vision of right eye for the last 2 months and had bladder bowel abnormalities for 1 month in form of increased frequency, urgency, and hesitancy. She had no history of altered sensorium, seizures, history of any other cranial nerve involvement, vertigo, syncope, thinning of muscle bulk, fever, joint pain, rashes, oral ulcers, hiccups, excessive sleepiness, or high-risk behavior. Her family and menstrual history were unremarkable. 5 months back, however, she was diagnosed to have TB meningitis and put on anti-tubercular therapy with poor compliance. Sir, shall I
wait here.
further?
So I will ask you. So what is your provisional diagnosis? And first you say,
Yes,
what can be the anatomical localization of the lesion and what type of lesion you suspect from your history? Then we will go for the discussion.
Thank you, sir. Sir, so as I said in my summary, that the patient in our setup had presented with sudden onset symmetric quadriparesis for the last 1 month, which was progressive for 2 weeks and then plateaued. Along with this weakness, which was hololimbic, that she had proximal as well as distal weakness in all 4 limbs. Along with this, she had also sensory loss, particularly negative symptoms of numbness, loss of touch, pain, sensation, loss of touch, pain, and temperature, as well as bladder bowel symptoms. So from this aspect, I would like to localize my anatomy of these lesions in the spinal cord. Peculiarly because she has quadriparesis, I would further like to say that the lesion is probably in the cervical cord. Now, along with this, she also had a complaint of blurring of vision in the right eye for the last 2 months. Because of this, because she has blurring, so this blurring could have been a local cause in the optic media, or it could have been some abnormalities in either the retina or the optic nerve. Now, from the history, she did not have any symptoms of redness, hearing, itching. So it is unlikely that there is a local, the lesion is localized to the optic media, and it is likely that it can be either in the retina or in the optic nerve. So to summarize again, I would like to localize my lesion right now to a cervical myelopathy and possibly a right-sided optic neuropathy. Now, coming to the myelopathy, sir, she had presented with symmetric weakness. She did not give any history of any girdle-like sensation. She did not complain of any root pain. She did not have any local complaints of pain over the spine. Thus, it is unlikely. I would rather favor a non-compressive etiology when it comes to the spinal cord rather than a compressive myelopathy. So, in summarize, I would like to say that she is probably likely has non-compressive cervical myelopathy along with an optic neuropathy. Right side.
Dr. Bhaskar, I
Yes,
have
sir.
few queries.
Yes,
You told
sir.
that the total duration is almost for 1 month, and first one limb is upper limb is involved, then the lower limb, then the contralateral upper limb. That is more a clockwise distribution.
Yes,
So
sir.
why you are not thinking the acute presentation, or it is rather a subacute presentation of a compressive myelopathy?
Yes, sir. That can also be a possibility in my in the given set of symptoms in my patient. But that can also be a possibility. But usually in these cases, if there was a previous compressive myelopathy which has proceeded to an acute event, there is usually a history of slowly progressive asymmetric symptoms, which suddenly it leads to a sudden symmetric paresis. There is usually a slow, prolonged history of an asymmetric weakness which develops over a period of certain days or weeks, and then it can lead to a certain symmetric, sudden quadriparesis. But then again, sir, I would also obviously like to keep that as a second differential in my patient, sir.
Bhaskar, tell me one thing, whether you are thinking it is a myopathy, myoneural junction, neuropathy, or
Yes.
myelopathy. How will differentiate between these things?
So primarily, first the patient complains of hololimbic weakness. Number two, the patient from the history that she gave was that she had complained of stiffness and there was history suggestive of flexor spasm. So I am not thinking in this case of any element lesion. Furthermore, the weakness, the
chart.
probably spastic weakness, I will need to confirm that from the clinical examination. But from history, as far as I'm getting, it is probably a case of spastic weakness. Along with the spastic weakness, she had also a complaint of sensory loss from the neck, from a definite level downwards, as well as bladder bowel symptoms. Then again, but she had no history of any disorientation, altered consciousness, any seizures or loss of consciousness. So it is unlikely that there should be the cortex is involved, and she had no history of brainstem cranial nerve lesion. So I would like to keep my.
What are the features if brainstem is involved? What are the features if the higher cortical centers or higher cortex is involved?
Sir, if the higher cortical functions are involved, the patient may complain with. It is usually present in quadriparesis. It is usually present in bihemispheric lesion. So a diffuse lesion should be present. In that case, the patient will present with seizures, disorientation, loss of consciousness, sir. And there can be signs of frontal release signs, which I will come to in clinical examination, sir.
And also features of the pseudovalvular palsy.
And also, sir, features of pseudovalvular palsy like emotional incontinence and so on, at least from history, sir. Sir, which was not there in my patient, sir. So yes, sir.
So you thinking it is a cervical cord lesion?
Yes, sir.
And your first diagnosis is a non-compressive myelopathy.
Yes,
differentiate diagnosis is a subacute presentation of compressive myelopathy.
Yes.
No, why not in the case of neuropathy?
Sir, in neuropathy, classically the lesion begins from distal to proximal, sir. It is usually bilateral symmetrical, and there is no history of any history suggestive of any spastic weakness or any flexor spasm. It is an element lesion, sir. And
an element is yes.
Continue. Yes,
continue.
And usually there is also, in long-standing cases, there is usually a history of atrophy or thinning of limbs, which begins from below upwards, that is from distal to proximal, sir, which was not the case in my patient, sir.
Professor M.K. Rai, please interact. Doctor, sir, you are mute. You are mute.
Sir, I can hear. Sir, I can hear you, sir.
Doctor Rai, you are mute. Please unmute.
Sir, you can unmute, sir, also.
Dr. Rai, you are co-host. You can unmute.
Okay. Orko Prabhu. Yes, do you find any lacunae in the history, or it is okay for the MD students?
Sir, it's a very well taken, well presented history. One thing I must say that when we are approaching a case of a quadriparesis, we should also keep in mind about he has a very well taken history of the limb weakness, but we should also keep in mind the history of any truncal weakness, whether he or she had any difficulty in rolling in bed, or she needed any support in getting out from bed. Because in assessing any root lesions, suppose in some polyradiculopathy, we may get such weakness. So this is one point in history which should have been mentioned.
Right. So that is a very important thing what he has mentioned. And Bhaswar, can you tell us if the patient has got a problem in the truncal muscle weakness? Where is the likely lesions? What is the likely chance of lesions? Anatomical lesion?
Sir, yes, sir. Sir, it can indicate a radiculopathy, sir, in this case.
Right. Very much. Or
a root lesion,
if there is any difficulty in lifting your, rolling the side in the bed or getting up from the bed, is any cervical lesion can cause any truncal problem? if there is
Yes.
any problem in the cervical region, can there be any problem in the truncal region too due to the cervical region involvement?
Yes,
Am I
sir. There
clear to
can
you?
be problems, sir, in the cervical, upper
So
cervical cord.
it could be radiculopathy, and also
Yes,
in
sir.
the cervical lesion we can get
Yes,
the
sir.
problem in the truncal region.
Yes,
So these
sir.
are the two things maybe sometimes the examiner asks.
Yes.
Now I will ask Dr. Mugundan is here, Professor Mugundan is here. So sir, can you like to make a comment at this stage?
Yes, sir. Sir, he has presented very well. I think it is a spastic symmetric quadriparesis with almost all modalities of sensories are involved. He didn't say at from the middle of the neck, he says, and also there is blurring of vision. So probably a bilateral pyramidal tract involvement at the cervical level, and also the sensory tracts at the cervical level, both posterior column and spinothalamic tract. And in addition, patient has got anterior to chiasmal pathway because it is unilateral vision loss. So probably a right optic neuritis with their cervical myelopathy.
Any question to the presenter? Have you got any question to the presenter?
Please put question to presenter.
Yes, yes.
Okay, I have got a question to Bhaswar.
Yes,
Bhaswar,
sir.
you have told it is a cervical myelopathy,
Yes, sir.
non-compressive cervical myelopathy you have told.
Yes, sir.
And always you like to exclude a compressive pathology, even if it is a non-compressive. But in neurology, it is a
Yes.
dictum that one should exclude the compressive pathology too. So
Yes,
anyway, can you tell me which region of the cervical area is involved? It is the RY cervical cord or lower cervical cord? What is your idea about this?
In my patient, sir.
Yes,
Yes.
I am asking
Yes.
you, Bhaswar. Can you
Yes.
tell that whether it is the upper cervical cord or it is somewhere else in the lower region of the cervical cord? What is your from the history? What is about
Yes,
the respiratory? What is about? Is the patient, have you taken the history of any respiratory problem in this case?
Yes, sir. She did not give any problem of any sort of any respiratory distress, sir. But I confirmed it with my clinical examination where I counted the single breath counting.
Right. I am
Yes,
not
sir.
going to clinical examination.
Okay,
What I am
okay,
telling
sorry,
you,
sir.
he did not.
From the
Why?
history,
Yes, sir.
What is the significance of asking this respiratory problem in cervical cord lesion?
Sir, the significance is because the C3, C4, C5 roots of the spinal cord supply the diaphragmatic muscles. So in case of a lesion that involves these roots, any one or more of these roots, sir, there can be diaphragmatic weakness which can lead to a degree of respiratory breathlessness or respiratory distress. Sir.
Very good.
So
Very good.
Very good.
And
So-
so
Yes.
you like to place your lesion above?
sir, I'd like to place my lesion above C5, sir, because all the four limbs were, she was complaining of spastic weakness, sir.
Very good. So you want to put it above C5. So
Yes, sir.
suppose the patient has got a C above C2, 3 like the lesion.
Yes, sir.
2, 3 like lesion. So
Yes,
what may be the things in the history?
So in case of a very high cervical cord lesion, like in C1 or C2, the patient can complain of some degree of occipital pain and neck stiffness, sir. He or she can complain of Lhermitte symptom where there is a pain, radicular pain shooting down from the back of neck while bending the head. She can complain, if it is in the region of foramen magnum particularly, the patient can complain of some degree of ataxia, some sort of nystagmus.
Bhaswar, we will come this in the examination part. We are discussing from the history.
Yes.
See, 3, 4 history is very important.
Yes, sir.
In concern with the upper cervical cord.
Yes, sir.
One is the facial.
Yes,
facial sensation.
I think he will be telling. He will be telling.
Okay.
He will tell. He will definitely is a good boy. He will be tell
from the history.
Professor Pal is asking.
Yes, sir. I am good.
What is about the facial area?
Yes, sir. The facial area, the patient will complain usually of a balaclava type of loss over the face.
Yes.
Because the spinal tract of...
Why? Yes, the other day we have discussed it. Why this balaclava type of facial loss occurs?
Yes, sir. Because the spinal tract of the trigeminal nerve will descend. The lower part supplies the more lateral half of the caudal part supplies the more lateral half of the faces than the proximal part, which supplies the more medial part of the face. So it often comes, the patient often comes with a complaint of an onion skin peel pattern of sensory loss.
So make it very clear to the listener. So mainly the area of the oral area and the perioral region, mainly the perioral region and the nasal area.
Yes,
okay,
sir.
this is supplied by your rostral part, and
Yes.
your lateral part of the face is supplied by the caudal area.
Yes, sir.
That this starts is actually it is just like a balaclava fashion or like a helmet fashion, because it involves the caudal area first. As a result, this is the onion peel appearance like that.
Yes.
That is one. Number two,
Yes, sir.
You can have some problem with
cranial nerve, sir. The lower cranial nerve, sir.
Yes.
Which cranial?
You can have this.
It is the 11th.
Sir,
No,
9.
it is the no, Bhaswar, it is the 11th cranial nerve that descend up to the C4 level. So you can have some shoulder and neck movement. You can weakness hand drooping. You can get it, and also the autonomic nervous system. Okay, these are the few important history that you get in the upper cervical cord.
That is very important. What Professor Pal is telling is very important. You can get some autonomic instability in the form of even the POTS. That is paroxysmal orthostatic hypoxia. Syndrome. Then orthostatic hypotension can occur. Then can be various types of autonomic disturbances. You can have sometimes vertigo, dizziness, because if the compression is high enough and the vessels are involved, especially the carotid which passes to the foramen transversarium, if there is any compressive lesion over there, you can get some amount of problem in the brainstem ischemia features. So vertigo, dizziness, etc. can happen. This is one. Number two is the facial area, the problem. The spinal accessory comes down. So you can get some weakness in the sternomastoid also. So you can ask him whether there is a difficulty in lifting the head from side to side or from just to bend it forward or not. You can have the Larmity sign, and these things are very important to ask when you take the history to find out the area of demarcation for the lesion. Okay.
Bhaskar, what will be the feature if there is involvement of the lower cervical cord? This is what you told about the upper cervical cord. Suppose the lower cervical cord is involved. There is a C7, C8 or T1. This area is involved. Then what will be the typical feature?
Yes, sir. So there will be element type of features in the regions which is supplied by the C7, C8. That is the medial side of hand, both upper limbs, sir. Yes, in the hand muscles. And there will be atrophy in some regions which will be supplied by the C7, C8 nerve roots. Below that lesion, there will be bilateral, symmetric, usually symmetric, or can be asymmetric in non-compressive lesion.
So basically, there will be
weakness. Yes, sir.
Yes, atrophy of the hand muscle.
Atrophy of the hand muscle.
Bhaskar, you also never forget, which I have actually forgotten to tell, that probably Bhaskar has already told, that there is also the Horner may be there.
Yes,
you can have some ptosis, drooping of the lid eyelid. That is only important point. And sometimes you can get on examination. It is not the history. In the historically, patient can complain of blurring, but the history will not give you what the cause of the blurring is. You can have nystagmus also. You can have nystagmus in the upper side because the medial longitudinal fasciculus actually goes down.
Professor Rai, these we will discuss in the examination section.
Okay, so
we are discussing the history.
Will come into the examination part. So, Professor
Bodua,
any comment up to this stage? Sharup.
Dr. Sharup Bodua.
Sharup, unmute yourself.
And now, can you hear me?
Yes, very much.
Very clear, very clear.
In the history itself, because it is a acute onset quadriparesis, so one should take history of vaccination or not. Fever, vaccination.
Very important point.
Unlikely sensory and bladder bowel involvement is there. But still, I'd like two lesions to be seen, that blurring of vision, because some of the neuropathies, those are like Miller-Fisher syndrome.
Yes.
This is the involvement of eye as well as the peripheral nerves. But anyway, neuropathy is slightly unlikely because of all modalities of sensory sensation is lost, as well as the bladder bowel. Otherwise, and Lhermitte sign, because the cervical cord lesion, we are thinking Lhermitte sign elicited. Thank you.
Yes.
Thank you, Dr. Boru. Now we come to Professor Soumitra Ghosh.
Soumitra is there. Okay.
Okay.
So, so far, what we have discussed, can you hear me?
Yes.
So far,
make a short comment.
So far, we have discussed, it is a very beautiful case which had involved a spinal cord, particularly, I think it is in the cervical cord, maybe in the middle portion, or it is a long segment in the cervical cord with this eye involvement. It is a special subtype. And definitely this vaccination history is important, what Dr. Boru has commented on. And let's see what is there in store, because this particularly this this myelitis optica is a special subset, and we'll have to see is what kind of NMO spectrum disorder can come in the future as a diagnostic modality. So let's see. Let's come the examination part. So Professor Rai, you can continue.
Thank you, Professor Ghosh. Thank you, Professor Ghosh. And before
Dr. Rai, I am coming to Orko for a few important issues for the recapitulation of the student. Let me, so Dr. Orko.
Yes,
please,
sir.
Previously you also explained the dermatomes. Now the upper limb dermatomes explain to the student, and you tell why false localizing sign often found in cervical myelopathy.
Sir, the dermatomes are from the C5 to the T1, if we go like this. So in the totally lateral aspect, if we come from the C5, then comes the C6. Actually, there are
show in your own arm. In your own arm,
yes,
you show to the student.
Sir, this part would be the lateral part would be the C5, the lateral part of the arm. Then it extends into the C6. Then if we go, that the thumb over here is supplied by the C7. Then comes the middle finger, and it's supplied by the C8. And the ulnar border, from the ulnar border of the little finger, it comes to the T1 up to the middle side of the elbow. Then a small patch over here is maybe supplied by the T2 part also.
And I think it can be little modified.
Yes, sir.
I mean, some kind of overlapping is there. I think Professor Rai is there, and he is the final judge.
In the supraclavicular region is a C3, C4, and the occipital is C2, and C2. Supraclavicular is C3, C4. So in the chest, C4, and here T3, T4 will come closer.
So very Orko, I like to be a little bit clarification. I want to be.
It is to be modified.
See here the deltoid is here, so that is considered to be C5.
C5.
Okay.
Yes.
Back of the head, he has already told about the C2. Okay. Now the deltoid is C5. C6 you classically this is the finger thumb. Thumb is the C6. Middle finger is C7. This is little finger is C8. Then this is C8, T1. This portion sometimes T2 comes, T1 and T2. Nipple is T4. This is a very important. This is T4. So this is the way you have to go down. So I think and another important landmark we started the other day, we discussed the T10 is a very important. That is the umbilical region. Inguinal is L1. It's a very important. Inguinal area. And dual limb we have already discussed. So these are the areas one should know, because they can ask you in the time of examination. Before going to the case,
Dr. Rai,
Professor Pal.
Yes, please wait.
You just try to recapitulate one thing, asking the student. I think Bhaskar should tell how, before you enter, how to distinguish between compressive and non-compressive.
Yes, this is very important. Bhaskar, Question
Yes,
is
sir.
how will differentiate between the compressive myelopathy versus non-compressive? If it is compressive, whether intermedullary or extramedullary. If it is extramedullary, whether intradural or extradural. Just to recapitulation for the student to explain.
Yes, sir. So first, I would like to distinguish between non-compressive versus the compressive myelopathy, sir. So in compressive myelopathy, usually the onset of the weakness is gradual and asymmetric, and in non-compressive myelopathy, it is usually rapid and acute onset and symmetric from the very beginning, sir. Number two, there is usually a history of a definite girdle-like sensation and a definite sensory level in case of compressive myelopathy, and usually there is no history of any girdle-like sensation or root pain or any definite sensory level in non-compressive myelopathies. There is usually a history of any local spinal pain, tenderness in case of a compressive myelopathy, and usually none in cases of a non-compressive myelopathy, sir. There may be on examination, there may be certain angulation and gibbous present, and there is
from the history, one important word you must have to use in compressive lesion. There is sequential involvement. This particular word you use, sequential involvement, is very important. It is non-selective. Sequential involvement. Whereas in compression, it is always selective.
Yes.
And it is discrete tracts may be involved in some cases.
Yes.
But that statement, what you have made, that is a non-compressive is always quick in onset. No, it is not correct. It only in case of non-compressive, case of ATM, that means acute transverse myelitis, which is usually subacute. To acute to sub necrotizing variety is acute. Otherwise, you can have non-compressive with a long history, like your combined subacute combined degeneration cord, motor neuron disease, letharism, Friedreich's ataxia. So these will take years together. So it is not very quick and like that, except in case of your acute transverse myelitis.
Yes.
Okay, then you proceed. How do you distinguish between these extradural and intradural?
Now, first is intermedullary. Now, first intermedullary and extramedullary.
Or extramedullary.
First.
Yes, sir.
How will differentiate?
Yes, sir. Between intramedullary and extramedullary, in extramedullary lesions, in extramedullary lesions, there is often a history of a root pain, definite root pain. In intramedullary lesions, it may be replaced by a ill-defined burning pain. Number two, in intramedullary lesions,
that
because of the arrangement of tract, funicular pain. Yes, sir. In coming back, if between in intramedullary lesions, the weakness is often descending in type, whereas in extramedullary lesions, the weakness is often ascending in type. From the same,
Bhaswar, make it simple. Extramedullary lesion, first because of sacral fibers laterally, so that is why the distal limbs are coming fast, gradually coming to the upper limb. Whereas inside is the cervical, so in intermedullary, first the upper limb, then is gradually going to the lower limb. Okay. And in intermedullary, bowel bladder and autonomic function will be affected first, followed by sensory motor. In extramedullary, motor sensory, followed by autonomic function. And posterior column will be affected late in intermedullary, posterior column will be affected early in extramedullary.
Yes.
Okay.
Can I make a small request?
Yes.
So 3 overseas friends are there from UK. One is Professor Singhal, one is Professor Parthurai, and one is Dr. Rahul Dev Sarkar. So can we add them in the panel? And so,
Also make them join as a panelist. Make them co-host.
Dr. Parag Singhal, Dr. Rahul Dev Sarkar, and Professor Parthurai. They are from UK. They have joined us, and we'll be happy to have their interaction.
Yes. I already instructed. And regarding the intradural and extradural, usually the benign lesion, so have a long course.
Yes.
But extramedullary, extradural, acute or subacute, trauma, tumor, tuberculosis, 3 common etiologies. So there will be more root pain, more gibbous, tenderness in the bony area, spine. This will be present. So this is the common. So now another important, very important history.
One point I like to add, Jatin, just one point to add. The extradural space is actually very small space. So as a result, the paraparesis or quadriparesis, whatever you can say, in extradural lesion, it becomes symmetric earlier than that of your compared to those of intradural lesion. Intradural, it takes long time to become symmetric, but extradural space is very small, so it becomes
Symmetry. Quickly becomes symmetry. So now we are coming to Professor Chatterjee. Professor Chatterjee, regarding the sensory symptom in cervical myelopathy has some typical different type of dissociative anesthesia we get. Can you explain to the students what are the different type of dissociative anesthesia we see in neurological practice?
Yes. Now, dissociative sensory loss can have a typical pattern where there are a dissociation between posterior column sensations and the spinothalamic sensations, and a number of conditions can lead to this. Bhaswar and all the students are aware of that. I'm just repeating. One is syringomyelia, as we know, where the posterior column sensations are preserved, but the pain, temperature sensations are lost early. But there are also other conditions where this may happen. One of them is the lateral medullary stroke or lateral medullary syndrome, where you can have a contralateral loss of spinothalamic sensations of the body, and ipsilaterally in the face, because of the involvement of the spinal nucleus of the trigeminal, you get a loss of pain temperature. But again, you don't get loss of fine touch. Apart from this, we have the case of anterior spinal artery thrombosis, where again, the posterior column sensations will be intact, but the spinothalamic will be lost. Also, another entity like the Brown-Séquard syndrome can be mentioned in this list. Okay, over to sir.
Yes, there are few other example of the dissociative anesthesia. One happens in the that I call that in case of trigeminal, because of the touch sensation crosses directly in the medulla, but pain and temperature descend, then go up and join in the medulla as a trigeminal lemniscus. So in the upper cord lesion, there will be loss of pain and temperature, loss in the face, but touch will be preserved. Another very interesting is the parietal lobe lesion. There may be position sense will be more deranged than the vibration sense. So parietal lobe lesion, so there will be loss of position sense, but vibration sense will be more or less preserved. So these are the again can also happen in diabetes also. Vibration sense is more lost in peripheral neuropathy rather than the position sense loss. So these are the same can happen in stapes dorsalis also, though nowadays we don't see the dissociation between the position sense and the vibration sense. So in neurology, there is a different modalities of dissociative anesthesia is present.
And
so Dr. May we proceed?
Another
Yes.
two things add Jyotirmoy,
Yes.
that is the your
Yes, sir, very good.
amyloid neuropathy, and as well as your sometimes you can come across in leprosy.
Leprosy.
So that is very important. Students should remember, because that is a dissociation of the small fiber and large fiber. So that these are the condition: diabetes, amyloid, leprosy. These three things should be told. So these are the ways center to the periphery. These are the ways of dissociated sensory loss as described. Nicely described. I think he should proceed, or shall
Yes,
we?
yes.
Yes. Then we will ask question from Dr. Pattore and other people from Liverpool when they come to the. I mean, after examination, we will ask.
No, after examination we'll come to them. So Dr. Shomita Ghosh, make them co-host. Dr. Ghosh, make them co-host.
Bhaswar, proceed.
Yes, sir.
I am not the co-host, so I cannot add them.
No, you can add. I make you co-host.
Okay,
You see, I have make you co-host. You can make them co-host.
Okay.
Bhaswar, you proceed.
Yes, sir.
Bhaswar, you proceed.
Yes, sir. Thank you, sir. So, to move on, I kept my anatomical localization as well as described. It was a spastic weakness, there were sensory symptoms, and there was no history of mental obtundation. So, it was likely a cervical myelopathy with a query optic neuropathy, which I will be able to further elucidate in my clinical examination. So, as the discussion proceeded, so it was, we thought of a non-compressive myelopathy or as a second differential and acute presentation of a compressive myelopathy. Then what about the etiology? So, for a non-compressive myelopathy, because the blurring of vision as a subset has improved slowly, spontaneously, and it was a sudden onset weakness, we kept demyelination as a possible etiology. And among these, infectious, parainfectious, connective tissue disorders, primary demyelinative syndromes, And as another differential, a possible vitamin 2 deficiency could also be present because of optic atrophy, possible optic atrophy and weakness. As a second major differential, because we also thought of an acute presentation of a compressive myelopathy, and as sir respectfully said, that we should always keep a compressive etiology in mind before we think of a non-compressive etiology, as the ADM in neurology. We also kept a caught spine with a fracture dislocation of vertebrae or a cold abscess compression as a second difference. So moving on to the examination. So coming to the general.
Just go to the previous slide. So Orko, do you think this is okay?
Sir, actually, they are almost correct. But one thing I must say that in the case of multiple sclerosis versus NMO, usually multiple sclerosis to begin with has a unilateral optic neuritis, and in NMO there may be together, the two optic nerves may be involved together, or there may be sequential involvement. Another thing, in metabolic vitamin B12 deficiency, the presentation is very acute in comparison to the presentation found in vitamin B12 deficiency. In the term of compressive, yes, there are few points. Compressive, such acute presentation without any pain, without any abnormal sensation in the neck, it's actually not present, because the acute causes, like where there is a maybe a posterior central disc prolapse, or maybe due to some hematoma or due to some abscess, those allied features are not there. So acute presentation of compressive myelopathy I would keep very low down, and also an acute presentation of vitamin B12 deficiency I would also like to keep it lower down.
Well taken, well taken. Now yes. I ask Bhaswar.
Yes, sir.
You have given. You tell me. You have written demyelination and you have written the tubercular.
Yes, sir.
So tubercular demyelination, what is the mechanism? How the tuberculosis cause demyelination? That is the most important thing, especially when you think in terms of paraplegia or quadriplegia.
Yes, sir. So in tuberculosis,
is it very common? Number one.
Yes, sir. It is a very it is an unlikely phenomenon, because most of the cases of tubercular involvement of the spine are due to direct bacterial invasion from the bone itself into the spinal cord, or a granuloma formation, or an arteritis, which can cause local ischemia of the cord. Having said that, there are case reports where it has been shown that transverse myelitis due to an autoimmune phenomenon, that is a demyelination, can occur because of an abnormal immune response to the tuberculin protein, particularly if the patient is on ATD and his immunity is improving, which can lead to an autoimmune reaction against the tubercular protein. So given the scenario in my patient, although it comes lower down as a differential, but given the presentation in my patient where she had a case of meningeal tuberculosis and she was on ATD for quite some time, albeit with poor compliance, I'd still like to keep this as a differential in my patient. Sir.
Thank you. Very good. Now the thing is, one thing I like to only add, this is a very, it's a very important things to know, that in tuberculosis, the way of spinal cord involvement, maybe the 4 things you have already told, how it can be involved. It can be an abscess, it can compress, it can be a port spine, it can be a fracture, it can be tubercular arteritis. Now regarding the demyelination, my point is, one point you are very much right, that one is an immunological mechanism. And number 2, never forget one thing, that is that tubercular bacilli itself can invade the blood vessels, and that they itself can cause some necrosis of the spinal cord. So that is the very rare case reports. There are few case reports all over the world. So these are the 2 ways you can have demyelination in tuberculosis. Thank you. Proceed.
Thank you, sir. So I'm moving on to the examination of the patient.
Yeah,
so
coming
to the
Proceed.
Yes, sir.
Yes,
sir. So in general examination, the patient was alert, conscious, and cooperative, oriented to time, place, and person. Her TCS was 15 by 15. Her build was average. Her weight was 56 kg, height 155 centimeters, and her BMI was 23.3.
How you have measured weight?
Sir, I did it from the record, sir, because I could not make the patient stand. So I noticed the last weight I got in January. Yes, sir.
Okay.
Yes, sir. So her facies was normal. Her decubitus was supine. She did not have any pallor, cyanosis, icterus, clubbing, or edema. No distended neck veins or any lymphadenopathy was found either in the cervical region or anywhere elsewhere. She was afebrile at present. Her pulse was 90 per minute of regular rhythm, normal volume, with no special character, no radioradial or radiofemoral delay, and all pulses were equally palpable, bilateral. Her blood pressure was 126 by 80 millimeters of mercury, and there was no postural drop.
How we have measured the postural drop?
Sir, I could not measure, I could not make the patient stand up, so I made the patient sit up with help for 3 minutes, and then I measured the BP after the patient was in supine position. From supine, I made her sit up, and yes, sir, but there was a back.
Why you have measured the postural drop?
Because, sir, there could have been, like I said, like it was discussed in cervical myelopathy, particularly in upper cervical cord lesion, there can be some autonomic disturbances, and we also, as a routine evaluation in all neurological patients, we should check for a postural drop of BP to exclude autonomic dysfunction.
See, Bhaswar, it is not very easy such a quadriparesis patient to for the stand up, maybe with the help, and to measure the postural drop. Rather, in such a patient, we should explore other avenues to assess the autonomic dysfunction. That will come later on. What are the modes of examination of autonomic dysfunction? Will come later on. Okay, proceed.
Yes. So coming to the neurological examination proper, her higher functions were normal, her memory and speech were normal, she had no meningeal signs at present, her spine and cranium was normal, and her height to neck ratio came to be 11:1.
Please stop here, Steve. Now I request Professor Chatterjee, the neck examination when a student is describing a cervical myelopathy, neck examination has an immense importance. So, how the student will examine the neck is the anthropometric measurement, number one. Number two, he told no meningeal sign. So, so regarding the neck rigidity, what is the method of examination of the neck rigidity? And from the three conditions, Parkinsonism, meningitis, and spondylitis. In three conditions, there will be neck rigidity, and how we will differentiate between the conditions. So, two issues you explain to the student. Professor Chatterjee, please.
Yes. Actually, during general examination, we examine certain things in the neck. However, in neurology, there are certain extra aspects which you should keep in mind. Though in our patient, maybe you are not thinking in those lines, still, for the sake of discussion, I'll say that when you examine the patient with quadriparesis, first you see the inspection of the neck, and certain measurements are important. Whether the hairline is low, which is actually defined when the hairline is beyond the C4 or at the level of the C5 vertebra, that is the low hairline. Another is whether there is webbing of the neck and whether the neck is short. Now, short neck is said to be present when you have made a ratio of the height is to the length of the neck and it exceeds beyond 30. Now, regarding the second part of Professor Pal's query about the neck rigidity, as you know that neck rigidity, we see if we are suspecting that the patient is suffering from meningitis. In that case, if you try to put the hand beneath the patient's head and make his chin touch the chest, if you attempt that, there will be a resistance because the extensor muscles are more rigid. Whereas even in a patient who has cervical spondylitis, there can be rigidity. So one way of differentiating clinically is that if you try to rotate the neck or do the lateral movement of the head, then there will be resistance in case of spondylitis, which may not be, which is not seen in meningism. Also, some degree of rigidity can be seen in extrapyramidal lesions. There, first you have to take into account the overall clinical picture and signs and symptoms of the patient to diagnose that. Moreover, it is said that I think Professor Rai will help me in this, whether the flexor muscles has a more rigid state than the extensor muscles.
Excellent. Very good. Very good. Excellent. This knowledge is very important. In case of Parkinsonism, it's the flexor muscle which is more rigid. In case of meningism, it's the extensor muscle is more rigid, and spondylitis, first the lateral movement will be restricted. But in but the advanced stage of meningism, all the muscle component may be rigid. So so now Bhaswar, you proceed.
Yes. I think, but you add one thing for the student's sake. If the patient develop encephalitis, meningoencephalitic picture, then you may not get any rigidity. That should be also told to the
student. Yes, rigid. Yes. Okay, proceed. Bhaskar, proceed.
Yes, sir. So moving on with my neurological examination.
Bhaskar, how you have measured the length of the neck?
Yes, sir. Yes. So how I measured the neck and the height neck ratio. So obviously, sir, I could not make the patient stand in this case, sir. But ideally, in such cases, the patient should be standing against a vertical background, which is straight, and the height total should be measured from the vertex to the heel of the patient, sir. That gives us the total height. The patient should be made to stand in such a way that her neck, his or her neck is neither extended nor flexed, such that the lower margin of the eyelid is parallel to the ground. Now, after we have got the height, we measure the neck, which is from the occiput, the basi-occiput, to the first spinous process, which touches the back of the patient, which is the vertical plane, which is usually in the region of C7. So from the occiput
to C7, C7.
C7. Yes, sir.
Very good, very good, very good.
Proceed. Very good, very good, very good. Proceed.
Okay, proceed. So coming to the neurological examination of the cranial nerves, her visual acuity was diminished in the left eye 6/9 and 6/18 in the right eye uncorrected. Visual fields were normal by confrontational perimetry, normal color vision bilaterally. No relative apparent pupillary defect was present in either eye. In fundoscopy, however, it showed a right-sided hyperemic disc with blurred optic margins. Her extraocular movements were full and free bilaterally. Her pupils were bilaterally normal and reacting to light and accommodating. No nystagmus was noted in the patient. And there was no signs of any other cranial nerve palsies in the patient.
Okay, Bhaskar, what is RAPD?
What is RAPD?
Yes, sir. Yes, sir. RAPD is relative apparent pupillary defect, which is usually an early sign of an optic neuropathy in a very early stage. It's a very early marker of optic neuropathy, sir.
It's a partial nerve damage.
With a partial nerve damage, sir. So with an RAPD, sir, it is, sir, shall I explain how to test?
Yes. Suppose in right optic nerve is partially damaged. Okay. In my right optic nerve is partially damaged. Now we proceed how we will examine.
Sir, first I would like to illustrate briefly the anatomical basis of this reflex. So, sir, the afferent goes via the optic nerve. It passes through the optic tracts and it enters into the pretectal nucleus, where it innervates the bilateral Edinger-Westphal nucleus, and from there the efferent nerve is carried by the third nerve, which connects to the ciliary ganglion, and from the ciliary ganglion, the short ciliary nerve supply the constrictor muscles, pupillar constricting muscles bilaterally. So the afferent limb of this reflex is found by the optic nerve, and the efferent is found by the third nerve. So coming to normally, sir, when I'm testing for RAPD, I take a patient to a semi-dark room, and we use the swinging flashlight or the torchlight test, sir. So when bilateral eyes are normal, what happens is when I test for RAPD, when I shine a light in this eye, for example, my right eye, there will be both direct and consensual constriction of both the pupils, sir. Because, and the same process is repeated when I take it to the other eye. However, in RAPD, sir, if this eye is normal, sir, when I'm flashing my light in my right eye, there will be both direct and consensual constriction in both the eyes. However, when I take the torch over to the diseased eye, that is the eye where I suspect that RAPT might be, because the afferent limb of this reflex is disrupted, the pupils will, from a constricted state, will either stay that way or not constrict further, but and can also dilate further. Plus,
This
the
explains
consensual.
Orko, Bhaskar, you explain why when you are putting flashlight in the abnormal eye,
Yes, sir.
eye having the partial damage of optic nerve, the pupil instead of the constriction rather dilate. That is the issue.
Yes, sir. Because, sir, there is partial optic nerve damage, sir. So, in
Yes.
a case of RAPT, sir. So,
Yes.
when I'm shining a light in the diseased eye, sir, the afferent limb of this reflex is being lost, sir. So, the pupil, even though the light is shown and the light is shown, there is no constriction of that eye, as well as there should be no consensual response of the other eye, because the afferent supplies both the efferent limbs of the lobe bilaterally, sir. So, instead of
just I add one line.
Yes,
When
sir.
you are putting the flashlight in the eye having the partial damage of optic nerve, the eye is perceiving as if it is a dim light because
Yes,
of the
sir.
partial
Okay. Yes,
damage.
sir. Yes, sir.
Because just before you put a light in the normal eye, so the diseased eye get a consensual reflex from the normal amount of light. But
Yes,
now the abnormal light, he thinks that it is a dim light, less light is coming. So rather than constriction, so it is dilating. There is a relative.
Yes.
Light is falling, but it is relatively less because of the partial damage. So
Yes.
there will be swinging, one constriction, one dilatation, one constriction, one dilatation. But both time you are giving light, ideally should be both time constriction. But
Yes, sir.
here you are getting one dilatation, one constriction.
Yes.
Okay.
Yes, sir.
So this is called Markasgan pupil. These are
Yes, sir.
features of the partial optic nerve damage.
Yes, sir.
Yes, proceed.
Sometimes you can get it also some retinal problem also.
Yes, sir. Yes.
So you can get not only it's a monopoly of optic nerve, but
Yes.
even if the retinal
Retina.
detachment, some acute
Yes.
angle glaucoma, you can get like that. That should be remembered. Okay, you
Yes.
proceed.
Yes, you proceed for the next.
Yes. Sir, I'm moving on to the examination of the limbs, sir. And trunk.
Yes.
So there was, I examined that there was no atrophy, fasciculations noted over either of the limbs or trunk. Coming to the power, the upper limbs showed a uniform weakness of 3/5 around shoulder, around elbow, and around wrist and fingers. And the lower limbs showed a weakness of 2/5 around hip, knee, and ankle. The tone, however, was increased in all four limbs with no ankle or knee clonus. Coming to the reflexes, the deep reflexes showed that the bilateral biceps, triceps, knee, and ankle jerks were exaggerated. The superficial reflex in terms of the abdominal and perianal reflexes were absent in the patient. The plantar response was, however, bilaterally extensor. In the sensory examination, there was reduced senses of fine, crude touch, pain, temperature over all four limbs and trunk, and lower limbs were more affected than the upper limbs in this case. The joint position and vibration sense was also impaired up to bilateral clavicular acromion process. The sensory level was therefore elicited at a level somewhere in the mid of neck corresponding to a level of C4. The cerebellar signs could not be tested in this patient. In the autonomic system, the bladder bowel, as I said, she complained of urinary urgency, frequency, nocturia, as well as some amount of hesitancy. The pulses showed that there was no irregularity and there was no tachycardia or bradycardia noted. As I said, there was no postural drop of blood pressure, and she did not complain or give any history of inappropriate sweating. In the other aspects, there was no evidence of any Horner syndrome in my patient, no frontal release signs, the jaw jerk was absent, and the single breath count of the patient, as I said, was 18.
Hold there, Bhaswar, hold there. So now I'm coming to Dr. Orko. Dr. Orko.
Yes, sir. Yes, sir.
Last day you beautifully explained two clinical methods, one plantar and one something else, I forget. So today, regarding the vibration sense examination, there are some pitfalls in examination of the vibration sense. Can you explain to the students?
Yes, sir.
How to proceed for the vibration sense and what are the pitfalls, common
Yes, sir.
mistakes?
Actually, vibration, most notably, we know that it's carried by the large fibers, and then they travel to the posterior cord. So, when using for a vibration sense, we should usually have a tuning fork with us. And one thing we have to explain to that patient that this is a very common mistake, that what is the vibration. For that, we have to first hit the tuning fork against a hard surface, not actually a hard surface making a sound. Usually we use the elbow, the ulnar border, and we hit over there. And then we have to place in a suspected normal area of the patient, like suppose in the forehead, a little to the side, and to explain him and understand this is not the touch we are asking, that this is the
Excellent.
actually the vibrating of the tuning fork you should be sensing.
Very good.
Then,
Very important.
yes, sir. After we are sure that patient has understood about the vibration, then only we can go for testing. So what should we do? We should go totally distally, and actually from distal to proximal we should come, tracing the bony landmarks. So the usual bony landmarks are the base of the first metatarsal, then going to the tibial tuberosity, then we have the both the malleoli, the medial and the lateral malleoli. Then we can trace up above the tibial anterior border of the shin, then go to the knee. After that, we can test in the anterior superior iliac spine. Then what we can also measure the sensory level of vibration. How should we do that? That we should go through each of the spinous processes of the vertebra and ascend up to a point where the patient cannot feel the vibration at all. Use of a tuning fork, usually a 128 or a 256 hertz tuning fork should be used in assessing the vibration of a patient.
Yes. So few points I will add. So
Yes.
we'll start from distally. Suppose we started from the great toe, and suppose patient say now I am not getting the vibration. Then we'll move the tuning fork either to the opposite same point or proximally. Transiently vibration can be felt, but if the vibration persists, moving to the proximal side or opposite limb more than 3 to 5 seconds, it is considered significant. Or transient just feeling of vibration is not significant, but it persists more than 3 to 5 seconds in the opposite limb in a similar position, then it is can be told that the previous limb vibration sense is impaired. This is one important. And if you get the sequential loss, suppose you are getting up to the medial malleolus vibration loss and above it is present, more suggestive of the peripheral neuropathy. But if you get the whole limb is lost from a certain point, that suggests more of the myelopathy. So vibration sense can give some idea whether it is a peripheral neuropathy or it is a myelopathy in this way.
Very good. I mean, explanation. So, in other words, what Professor Pal was telling, this is one of the way to find out the level of the lesion in compressive myelopathy.
Yes.
Okay. So you go from below and up, and at the level of the D10 or I mean vertebra, maybe D7, there is a loss of vibration from D7 onwards. So probably
we can get a bend up.
Yeah. So then with a bend, so you can make out the lesion is where is the situation of the lesion. This is one important. Now a very funny question, very interesting question. One examiner was there with me for a long time. I was an examiner, of course. So he asked a question to the student that what are the uses of tuning fork and what other condition you can use the tuning fork. So your answer should at that time, the student told one or two. I think the very interesting. You can use the tuning fork for your Renis and Weber. You can use the tuning fork. Of course, the hertz will be different, 512 and 924. So 556. So you can think about the 128 classically for your lower limb vibration. But when you come to the ER, you have to see how much hertz you are actually using. This is another use of tuning fork. Number 3, sometimes is a crude method. We use the the bottom part of the tuning fork to see the cold sensation. sometimes we place this you don't have any ice cold water or something like that. So from our, it is a very crude way of seeing your just touching whether you are feeling hot or cold, like that you can place it in the patient's skin and whether he or she is feeling the cold sensation or not. So these are the ways sometimes the examiner asks. This is just from my experience.
Very good, excellent, Professor Rai. So I am coming to the orco, to the student.
Yes,
you describe another two issue very common found in the cervical myelopathy. One is the crossed hemiplegia, and another is the clockwise development of the weakness. So you explain how the anatomical crossover of the fiber or position of the fiber can explain the two issues frequently found in compressive myelopathy. First,
yes,
you
sir.
say the cross hemiplegia.
Okay, sir. Sir, one thing I would like to say that when the motor fibers are descending, usually obviously the hand has to be supplied first. So the fiber supplying the hand lies more laterally, and the leg, it is more medial. So what happens similarly in the hand, then on one side there is the fibers of the hand, then the fiber of the lower limbs, then on the other side medially it lies the of the lower limbs, then towards the more laterally of the other side it comes the hand of the opposite side. So what happens when there are four columns, if we can see that hand of left side, the leg of left side, then the leg of right side, and the hand of the right side. So what happens when extramedullary compression is happening from laterally? What happens? What is first involved is the hand of the left side, then it occurs to the leg of the left side, then what comes is the leg of the opposite side, and then what comes is the hand of the other side. So this is a U pattern. So U pattern is formed. Now about the crossed, that is what is the crossed hemiplegia, occurs also in the high cervical cord injury at the level around of foramen magnum, where what happens, there is decussation of the pyramidal
Upper
tract.
limb.
Yes, sir. Yes, sir. What happens is the decussation of the upper limbs occurs a bit more proximal than the decussation of the lower limbs. So as a result of which, at one level there is fibers supplying the upper limb of one side, whereas at the same level the fiber supplying the opposite side lower limb is present. So as a result of which, the compression at that site around foramen magnum leads to such crossed hemiparesis, where there is weakness of maybe the left hand and the right lower limb.
Very good, very good. All students who are connected.
To what should be used, Orko?
Yes, sir.
The first the phenomenon which you have told, just for the sake of the postgraduate students, I am telling them it is called around the clock pattern or Aldrich phenomena.
Aldrich
That is a very
Aldrich phenomenon.
EHRLIA. And the second part, what you have told, it is called the cruciate hemiplegia.
Cruciate hemiplegia. Yes.
Okay. So these are the two things.
This is very important. Cruciate hemiplegia and Aldrich phenomena. All students should remember. Okay. And next time coming to Dr. Mukundan. Dr. Mukundan. So another very important issue for any myelopathy is the bowel bladder dysfunction. Can you briefly explain the control of the bladder physiology and what are the how Dr. Mukundan connected?
Yes, sir.
Yes, yes. And what are the bladder abnormality we get in myelopathy?
Sir, for the exam point of view, I just discussed.
Yes, yes. For the exam point of view, important exam point of view, bladder control and pathology.
Bladder is supplied by parasympathetic system and sympathetic system and the local the somatic nerves. The parasympathetic, we have S2 to S4. It supplies through pelvic nerves and acts as motor nerve to detrusor muscle and transmits sensation from bladder, suburothelium and detrusor. Whereas the sympathetic system, that is T11, 12, L1, L2, the supply is via hypogastric nerve through pelvic plexus. The local supply is through pudendal nerve. Then we have the cortical center in the frontoparietal region and also pontine micturition center. So what happens uh, if the bladder fullness sensation passes through pelvis and pudendal nerves via S2-3 spinal segments to periaqueductal gray matter, and this mediation is to the median pontine micturition center, which in turn signals the detrusor center through pelvic nerves and the bone of nucleus to the pudendal nerves. So the medial pontine micturition center is inhibited by the cortical center until it socially appropriate to void. The sphincter and detrusor have reciprocal activity, thereby leading in filling and voiding. The internal sphincter prevents leakage during filling the bladder and prevents the reflux of semen into the bladder during ejaculation. It serves only a small role in micturition control. Sympathetic nerves have no part in micturition. If there is stimulation of the parasympathetic nerves, it causes contraction of the detrusor and relaxation of the internal sphincter. Whereas the sympathetic, which causes relaxation of the detrusor and contraction of the internal sphincter. In the type of bladder, we come across clinically only 5 neurogenic bladder. We have 1 cortical uninhibited bladder and 2 automatic bladder, 3 autonomous bladder, 4 motor paralytic bladder, 5 is sensory paralytic bladder. So even in this case, we did not discuss about the localization of bladder in the history. So in case of cortical uninhibited bladder, which occurs in strokes and other conditions, where we have to look 3 or 4 points in the history, we have to ask. So is there any bladder sensation is present or not? So what is there any history of residual urine? Then we have to ask about hesitancy, precipitancy, urgency, incontinence, all these things we should ask. In case of cortical uninhibited bladder, the bladder sensation is present. It is like child's bladder. So the capacity is very small, very minimal amount. Whatever the urine collects, so it is just passed like a child. So they will have frequency of urgency is present in these type of patients. The next comes like our case, automatic bladder, where the lesion is above the spinal center. Above the spinal center, it is involved. So it is called automatic bladder or human bladder. So in which the bladder sensation is variable. During acute phases of spinal shock, the sensation is absent. While during recovery of the spinal shock, the sensation may be present. Then the capacity is small and the residual urine is very minimal. The common symptom is they will have difficulty in initiating micturition, urgency, and the precipitancy sometimes there. Next condition is autonomous bladder, lower motor neuron bladder. The lesion is at the level of the sacral center, commonly occurs in caudaconus lesion. So patient will have the symptoms of perianal sensory loss, because the S234 is involved, and urinary incontinence or fecal incontinence may be there, where the bladder sensation is absent, and they will have some dribbling incontinence may be present. The capacity is not greatly increased, whereas the residual urine is moderate. The residual urine is moderate. So the next comes is the sensory paralytic bladder. So this is our the other is called deafferented bladder, where the posterior roots or post-root ganglia may be involved, where the sensation is absent. The patient will have large amount of residual urine. So in which type of bladder lesion you will get very large amount of residual urine, that is sensory paralytic bladder, which occurs in tabes dorsalis. So the lastly we have motor paralytic bladder, which occurs in polyradiculopathy. Commonly we see in GVS lesions, where they will have painful distension of the bladder. The bladder sensation is normal. The capacity and the residual urine will vary. So we have to know all these type of bladder accordingly. So we should elicit history accordingly, that the bladder sensation is present or not. So what is the urinary symptom? So what is the level of this thing? Even after passing urine, they will say, I have incomplete emptying of urine, like that they will say. So based on this, we can localize even at the history level about the types of bladder. So in this case, so probably the lesion is above the sacral center, that is automatic bladder or VMN bladder. Thank you.
Thank you, Dr. Mukundar. You have nicely explained, and you are also a very good writer. I request you give a write-up, the bladder dysfunction in neurological disorder, and I will publish in JIMA, and every student can read it. So next month I need from you from this, or I will publish in my another journal, Bengal Physician Journal, your article. So regarding the my one comment regarding the jerk and sensory examination, though may not be applicable in this case, but when you are examining or describing a quadriplegia, two jerk, particularly the supinator and finger flexion, to be mentioned. May not be applicable here because all jerk are exaggerated. Another regarding the sensory examination, separately the sensory examination of the face to be mentioned separately because of the presence of trigeminal. So this is the comment I can comment at this moment. Now we'll come to Professor Swarup Bodua, your comment up to this level. Professor Bodua, you have a vast experience of taking exam.
Yes, whatever. Can you hear me?
Yes,
Yes,
very nice.
yes.
Yeah, what you have pointed out regarding the examination of the face is correct. And anyway, very nicely, though not in a format we in a writing examinations. Okay, because reflexes, some people write motor, sensory, then reflexes, because reflexes say they got a both sensory and motor element. Anyway, now we are landed up with a spastic quadriparesis with an optic neuritis. Let's go for the differential diagnosis with bladder bowel involvement and spastic sensory bladder bowel involvement as well as optic neuritis, optic head. So now let's go for the differential diagnosis.
So Bhaswar,
Yes,
just
sir.
you tell me one question, because I mentioned the supinator jerk is very important to explain or to describe why we are dealing a quadriparesis case. Why?
Sir, in case of, there may be inversion of the reflexes involved. For example, if a lesion is in the C5, C6 region, the supinator jerk, there may be inversion of the supinator jerk, which can pinpoint a lesion in the region of C5, C6.
Supinator by C5 and C6.
Yes, sir.
The arm, the flexion is C5 and
Yes,
finger movement by C6.
Movement is C6.
So,
yes,
so if there is lesion at the C5, the arm flexion, this part will be lost, but finger flexion will be exaggerated.
Yes, sir.
Okay, so this is called inversion of the supinator. That means one component is lost and other component is exaggerated. That is called inversion of supinator. So
yes,
inversion means lesion at the C5, not C5 C6. Lesion at the C5. This is the importance. So now we proceed. Dr. Rai, may he proceed?
Professor Rai and Professor Pal.
Yes.
Professor Rai and Professor Pal. Professor Giridhari Kaur is here. Professor Bhaswar Ghosh is here. And Professor
Make
Patura
them
is
co-host.
here.
Make them co-host.
We'll make them
Already
co-host.
If you ask them for any
Make them
comment,
co-host.
Okay.
Professor
Before,
Pathurai, Bhaswar Ghosh,
yeah.
and Giridhari Kaur are there.
All will take their opinion.
Okay. Thank you.
I think Bhaskar,
Yes, sir.
Orko is there. Orko.
Yes, sir.
Oh, there is a question in the chat box. Why you use 128 hertz in vibration sensation? There is a question by somebody.
Sir, much more finer frequencies are difficult to be picked up by the peripheral nervous system. So, more coarser one is selected.
Coarser one is selected, number one. I agree fully with you. Number
Yes,
two,
sir.
whatever you do with the 128 frequency, you cannot keep it for more than 10 to 15 seconds. So you need a shorter duration to
Yes,
get
sir.
the perception. So as soon as you do it, one is the more peripherally you go, you have to pick up these things. So the lesser number of frequency is necessary. That is the reason for using. Okay. He has also asked another thing. Can you again explain the cruciate hemiplegia, what you were actually telling?
Yes,
Again,
sir.
just tell two lines and finish.
It is nothing but it is the differential decussation of the pyramidal tract. What happens if this is the brainstem? If we can imagine the brainstem over here, if I could draw, it would have been good. So, however, if at a level the fibers for the hands, they decussate proximally. So, at a point the proximal fibers, the hand fibers have already decussated. However, the leg fibers haven't decussated at that point, and they are decussating a bit more distant. So what happens if at that point where the hand fibers have already decussated but the leg fibers have not, at that point if there is some compression, so what happens? The hand fibers of the opposite side gets affected and the leg fibers of the same side gets affected. That's why there is cruciate paralysis, cruciate pattern of paralysis.
Very good. Yes. One side already crossed, another side not crossed.
Yes.
The lesion at this level. Okay. Bhaswar, you proceed.
Good evening. Am I audible? I am Dr. Giridhari.
Yes, sir. Yes, sir. Most welcome, sir.
So one thing about the vibration. So we use 128 because the vibration sense is such that lower the frequency, it is better felt.
Yes.
And
Yes.
auditory sensation, higher the frequency, it is better heard.
Yes.
So as we go for testing of hearing, we go for a higher frequency like 556 or like that. And for vibration sense, as it is for this to feel, this is a perception, but this is a vibratory perception, it is the lower frequency. So lower the frequency, it is better felt. Higher the frequency, it is better heard. So we use 128. And about Dr. Roy, you just mentioned about the crossed hemiplegia. Now, crossed hemiplegia, as I understand, is when there is a lesion in the
is one-sided hemiplegia and opposite-sided cranial nerve.
cranial nerve.
I asked
that
cruciate hemiplegia.
But before that,
one side,
was
right-sided upper limb and left lower limb.
yes,
Actually,
it's okay,
I fully agree with Professor Giridhari Kaur. Initially, it was discussed as crossed. Actually, that should be cruciate. And there should be a difference between crossed and cruciate. Yes.
crossed was
I did not
mentioned,
comment
so I
at
am
that time,
telling.
but Professor Giridhari Kaur has rightly picked it up. Thank you.
Yes, sir.
Less the number of the frequency, more is the size of this frequency wave. This we know the physics. The larger is the wave pattern, and these nerves can feel it better.
Okay.
Okay,
So,
proceed.
Bhaswar, you proceed.
Thank you,
Proceed for the differential diagnosis.
Yes, sir. So the other system examinations were essentially normal with no respiratory, cardiovascular, gastrointestinal finding. So summarizing again, sir, the general examination of the patient was unremarkable. On neurological examination, the patient was found to have normal sensorium with no meningeal signs and symmetric spastic quadriparesis and loss of all modalities of sensation in limbs and trunk from the middle of neck downwards. All her deep tendon reflexes were exaggerated and her plantar responses were extensive bilaterally. She had decreased visual acuity in both eyes, but the right was more affected than the left. No RAPD was present and no evidence of other cranial nerve palsies were found. She also had evidence of UMN type of bladder and bowel involvement. her single breath test count was 18. Her spine and cranium height to neck ratio was normal. There was no nerve thickening. The examination of the other systems was within normal limits. So again, to localize, we are thinking, as we had discussed from our history, it is telling with the finding that it is a cervical myelopathy, and because the sensory level was somewhere around the middle of neck, it was most likely around the C4 segment, and again possibly non-compressive etiology. We had found with the possibility of a right-sided optic neuropathy. So coming to the possible etiologies, we are thinking of a diminutive cause in this state, where it is either an infectious or a para-infectious cause, a connective tissue disorder like an SLE sarcoid Sjogren's, or it could be a primary diminutive cause like multiple sclerosis or an NMO spectrum disorder. Because we found that.
Yes, proceed.
Sir. Yes, sir. Because we found that the spine and cranium, there was no gibbous, no angulation, and no other evidence of any compressive etiology. We kept out the differential we had previously had of an acute presentation of a cord spine, and there was no suggestive associated neuropathy. So it was unlikely that the patient had a myeloneuropathy, and given the presentation, it was unlikely that a vitamin B12 deficiency could explain all this. So shortening our differentials, it was either a diminutive, possibly a diminutive cause, which was could be an infectious, connective tissue disorder, or a primary diminutive cause.
Okay, Professor Chatterjee raised hand. Yes, please.
I was just, I may have missed. Have you mentioned the ophthalmoscopic findings?
Yes, sir. Yes, ma'am. Sorry. I mentioned this.
Okay, what was that?
So it showed a right-sided hyperemic disc with blurred optic margin. The left eye showed normal findings.
Okay. Oh, thank you.
Any comment, Professor Chatterjee? So now I am asking Dr. Bhaskar. Now we explain what are the features for the foramen magnum lesion, what are the features for the upper cord lesion, what are the features for the C5 lesion, what are the features for the C7 lesion, what are the features for the C8 lesion. Just very brief, you tell. This is very important for cervical myelopathy. Foramen magnum. What are the special character of the foramen magnum?
Yes, sir. So in the region of foramen magnum, it is a high cervical cord lesion. So along with the findings I described, there is usually a presence of a downbeating nystagmus. There may be cerebellar ataxia present. There may be papilledema present due to increased intracranial hypertension. Sir.
Very good. And also,
the other findings like, sir, the lower cranial pulses like 19, 11, 12, the balaclava pattern of facial.
Very good, very good. If there is lesion at the C5,
if there is lesion
at the C5.
Yes, sir. If there is lesion at the C5, then we will find element features. At the biceps jerk will be absent, sir. There will be there may be atrophy of the biceps muscle, and below that, above that, all the findings will be normal, and below the C5 level, that is from C6, that is from the middle finger to the medial side of hand, and below trunk and in the lower limbs, we will find features of human pulses, that is exaggerated reflexes, spastic weakness, upwards extensor bilateral plantar responses.
So, biceps absent, tricep exaggerated, and inversion of the supinator.
And inversion of
the supinator. What is the C7? What is the character of the C7?
Sir, in C7 lesions, usually there may be atrophy of the hand muscles provided, and there can be there is spastic paralysis again from C8.
That is common. No, that is common for all.
Yes,
especially triceps will be lost, biceps will be lost,
biceps will be normal,
and finger flexion will be exaggerated.
Yes,
because this is by C8T1.
Yes. Finger flexion will be there, tricep will be absent, and in this area,
bicep will be normal. What happens in case of lesion at the C8T1?
In lesions of the C8T1, sir, we will get mild numbness in the medial side of hand.
Of the arm.
We might, and below that, we will get spastic weakness.
No, that is common for all. Now the finger flexion will be lost, but triceps and biceps will remain.
Yes, sir.
See, finger flexion by C8T1.
Yes, sir.
Biceps by C5C6. Biceps and supinator by C5C6. Triceps by C6C7.
C6C7. Yes, sir.
So finger flexion will be lost. Finger
Yes, sir, the
flexion
finger-
loss, biceps triceps normal, and
Normal,
lower
sir.
limb exaggerated. This is the
Yes, sir.
picture.
Yes.
So now we are coming very important issue in cervical myelopathy, and there is a craniovertebral anomaly. Professor Chatterjee, can you? This is a very important issue, and not we are not much aware. So, and last year, Dr. Mukundan has written a very nice article in Progressive Medicine. Now, I request Professor Chatterjee, you give brief overview of how and when we suspect the craniovertebral anomaly. Share your slide.
Yes.
It is with Bhaswar or separately?
No, it is not with him. Is it visible?
Okay, Bhaswar. No, slide not visible. Now, it is the same slide of the Bhaswar.
No,
It is
no.
okay. It is okay. It's okay.
What
Start.
is it? Is it
Visible,
visible?
Visible.
Yes,
Visible,
you
but
make it a big, make
large.
it a large screen. Yes, it is visible.
Yes, yes, it is visible.
Yes,
now. Yes.
actually it is late, very late, and I'll be very brief. I will just be pointing out what the students should read out. I don't want to go into much details. Now, this is the picture of the craniovertebral junction, which is made up of the occipital bone, and here is the cross section of the foramen magnum. The first cervical vertebra, which is called the atlas, and the second cervical vertebra, which is the axis. Now, the odontoid process protrudes into the atlas and is held together by a transverse ligament. Now, disease processes involving this area will have effects on very important neural structures that are coming out of the cranium and into the vertebral canal, as well as there will be effects on the important vascular structures, even part of a cerebellar tonsil or CSF spaces. Now, I will just name a few common skeletal craniovertebral anomalies. They are basilar invagination, platybasia, malformations of the atlas, Klippel-Field anomaly, and atlanto-occipital dislocation. There can be neural anomalies as well. I won't go into the details, just the names, the Arnold-Chiari malformations, syringomyelia, Dandy-Walker complex, etc. Now, the symptoms that happen are either due to compression of the neural tissue directly or due to compromise of the blood supply or a combination. And usually when you suspect, you find a more or less, you can find a young person, though the range is from the first decade to the fourth decade, and the patient comes with pain in the neck, stiffness or restriction of movements. There can be symptoms of transient vascular events. The patient will have motor deficits like our patient quadriparesis, though this patient has a totally different clinical presentation. There may be posterior column signs, brainstem dysfunction, cranial nerve involvements, cerebellar signs, even Lermite sign. Sir, Professor Mugundan was talking of the Lermite sign, I think. So that can be present. Now, as I was telling before also, that you need to find out whether this patient has a short neck or there is a low hairline or not. As also, you should take into account whether there are facial malformations, palatal defects, limb malformations, and shoulder defects. Many are there. I won't go into the detail. You please go through your books and read it. Now, the diagnosis, clinical as well as radiological. So some questions are asked. Now there are multiple, more than 20 lines and angles written in the books. You don't need to go into all that. I will just tell you of these 3 lines. I think even my other teachers will also help me here what they ask in the examinations. But these three lines, the McGregor, Chamberlain, and Macri lines, you need to know what they are. You can see it in the picture. The Macri line is between the two ends of the foramen magnum, and the Chamberlain's line, the pink line, it comes from the end of the hard palate up to the posterior lip of the foramen magnum, whereas the McGregor line is from the end of the hard palate to the below the occipital bone. Now, what is the importance? The importance is that the odontoid process in the normal, the values are given that it should not cross these lines too much, and if they are there, then you have to suspect that maybe there is a problem with the base of the skull. There can be platybasia or a basilar invagination. Okay, the angles I won't go into the details of the angles, but there are a number of angles which are also seen. And I think I should stop here because there is too much discussion is not needed at this point, but you should know a little about craniovertebral anomalies.
Thank you, Professor Chatterjee. Dr. Mukundan, you are the author of the chapter. So, your any further comment regarding the craniovertebral anomaly?
Whenever a patient comes to us with trivial history of trauma, we should suspect CV junction anomaly, where there is gradually progressive spastic paraplegia, lower cranial nerve involvement, descending tract of trigeminal nerve involvement, features of Horner syndrome, and the examination might show the triad of Field's triad, that is short neck, low hairline, and restricted neck movements. Then we have to suspect CV junction anomaly. Usually, skeletal anomalies will show all these features. The soft tissue anomaly will have more of cerebellar signs. We have to suspect CV junction in these type of patients. So the quadriplegia, if the level is above C3, then we have to think of high cervical condition. If it is associated with syringobulbia, then we have other signs also in the form of brainstem signs. Thank you.
Thank you. Now, excellent.
One point I like to add, Jyotirmoy, because this is very important to remember. One of our pioneer in our country, he is no more. He is Professor Wadia. Everybody knows his name, who actually invented the SCA2, which is slow saccades and peripheral neuropathy. Yeah, Wadia. He had a lot of articles on the craniovertebral junction anomaly, and actually, if you can touch your chin with the shoulder, you can touch it. You can touch it. In case of craniovertebral junction anomaly, the low hairline, this neck height ratio, and other signs, along with these things, if you cannot touch this one, this craniovertebral anomaly, people usually cannot touch their chin into the acromial process. That is another, this is called Wadia sign.
Thank you.
Oh, thank you. Very nice.
Very nice little anecdote. Very nice too.
Very nice. Every student should write down these important findings. Now, we have some guests from UK. So I'll come one by one regarding the comment. Finally, Professor Imkera, you will sum up and give final comment. So, Dr. Shinghal, your comment. Dr. Shinghal, Dr. Pankaj Shinghal, connected?
Dr. Shinghal is not there, I think.
Not Dr. Rahul. Rahul collected.
Hello, sir. Yeah, I am here.
Yes,
thanks.
Yes, Rahul.
So thank you everyone for the very comprehensive discussion. And I and Dr. Shinghal initially joined to see what the way the discussions are usually taken place so that we can probably contribute from British Association of Physicians of Indian Origin, BAPIO, in future. And we are very impressed, obviously, with the quality of discussion and the way Bhaswar has presented as well. And I don't have anything much to add. Obviously, clinically, I am a respiratory and critical care physician, not a neurologist. And I would like to obviously be involved in this in future. And all the best to Bhaswar.
Thank you, sir.
Thank you. Now Professor Parthuroy, Soumitra Ghosh, Parthuroy is connected.
Yes, he's there.
Where is Dr. Roy?
হ্যাঁ আমি আছি বাংলায় বলবো না ইংরেজিতে বলবো
ইংলিশে অল নট বেঙ্গলি
ইংরেজিতে বলো শর্ট কমেন্ট করো পার্থ কিরকম হচ্ছে আমাদেরটা হাউ উই আর ডুইং
Oh right, so you don't want me to comment on the case. Oh, I thought I was going to give a neurologist's opinion. Right.
No, you give both the opinion, you give all the opinions, whatever you like, you add in a short time.
Okay.
Medical, non-medical, whatever may be.
All right. Okay. Well, my respects to Professor Mrinal Rai, Professor Mukundan, Jyotin Moy, and all my colleagues and contemporaries, as well as my juniors. I am extremely impressed by the quality of discussions I've been hearing through the entire Corona period. Particularly if you ask me to comment upon these two last sessions on paraplegia and quadriplegia, I left India in 1994. And I just went back to give an exam in GB Pant and in NIMHANS for my DNB in neurology. I can definitely assure that the quality of discussions exhibited by Bhaswar this week, and last week it was the lady Manali, is exemplary. And I think they have had the stamina and the perseverance and the knowledge depth to be able to counter stalwarts like Professor Jyotin Moy-Pal and Professor Mrinal Rai, Professor Mugundan, Professor Chatterjee, and Professor Barua and Professor Kaur. So I'm really impressed by the standards of academics. And I think hats off to the organizers, Professor Soumitra Ghosh and Professor Jyotin Moy-Pal, for leading all this through the API West Bengal branch. It has really been a shining showcase for all of India. And I wish I had all these privileges, and I would never have left India for 30 years if the neurology was available like this, at this level, when I was, leaving it because there were no DM seats at the time for me. Right, so we should continue with this.
You are an eminent neurologist. From the neurological point of view, please encourage our PGT Bhaswar with your few words on neurological aspect of this case.
And your few tips on this case.
Yes.
Okay. Yes, I've been taking notes as I do in Queen Square in the grand rounds. First of all, Bhaswar, I'd like to ask you that this patient had 5 months ago from the onset of the weakness, an episode of fever, headache, and double vision on right lateral gaze, for which he went on to ATD since January 2021 and was poorly compliant. Now, and then there was this right eye problem, and then was the paraplegia. You did not elaborate very much on that initial illness because we don't have the diagnosis as yet. But what was that episode? Was it a case of bilateral optic neuritis? Why was there fever? Why was there headache? I was just inquisitive for the signs and the symptoms and the therapeutic deduction at the time to lead to the diagnosis of tuberculosis. That's one. The second thing I'd like to talk about is basically when you talked about the right eye getting better after 2 months, the blurring of vision, was it sort of a gaze palsy, INO type thing, or was it optic neuritis? I know you have shown us afterwards there is bilateral optic neuritis, haven't you? 6/9 and 6/18, with the right eye showing evidence of papillitis possibly. So that was my concept there. On the way, I picked up a clue from Professor Jyotin Moy-Pal about the false localizing sign in the cervical region. I don't know the answer to that, so I would like to know about that. And we are very much into genetics in neurology. So I think family history was never taken in this patient. I'm not saying it's contributory, but I think we should make it routine practice because genes and neurogenetics and genetics across the board has come up big time. So we have to, but where is the, thank you very much. Apologies. I missed that. Thank you very much.
I appreciate
yes,
that
so I think
issues raised by Professor Rai. because this very important question has been raised, whether it has any connection with the past history of tubercular meningitis and treated possibly, I mean, insufficiently. So whether it can be a direct complication of that, or it is a different disease, just as a coincidence. So very important question, sir.
And craniovertebral anomaly was a good revision because Professor Mukundan has given us a good video on the GMA online, and I have enjoyed attending it as well as hearing him firsthand. It's a very complicated area, but it's come of age. And so anyway, all I can say is I think we are doing very well, and we, I think, all deserve a pat on our back, but we must keep the flag flying even higher. And I think our postgraduates have a lot to teach me. And I would love to work with you and learn with you. So good luck. And thank you for letting me speak.
Thank you, Bharto. Thank you for your excellent comment. And 2 points which you have told, definitely Bhaskar will take care of those 2 points. And he will have definitely think, because we are already 10:30. Now I
cervical spine
Professor Giridhari Kaur is here.
Giridhari Kaur.
Professor Giridhari Kaur is here.
Giridhari Kaur, is Sumitra connected?
Yes, Professor Professor Giridhari Kaur is connected.
Yes.
Professor Giridhari Kaur, please comment, give us some encouragement to the students.
No, it's a very nice presentation. I should say quite elaborate and exhaustive. So, ultimately, one question. My question is, what is the final diagnosis? Is it
what is your final diagnosis?
Sir, can I go through the investigations before?
No. The investigation is not required.
Or is it?
No.
Okay.
Here we will discuss only the clinical part. So,
okay, sir. So from the history and examination, I would like to keep my diagnosis as a transverse myelitis involving possibly the C4 level of the cervical cord. Obviously, it's a non-compressive etiology, and we were suspecting a demyelinating lesion, which can either be, usually in this case, I would like to keep a tubercular etiology in the first hand and keep demyelination syndromes, both primary and secondary etiologies, as another differential. And the patient was not complicated with any bed source or any pressure source. So it is a transverse myelitis involving the C3 level of the spinal cord, possibly due to tubercular etiology, and not complicated by any bed source. But I would like to investigate my case further to reach final diagnosis.
So patient initially was quadriparetic, then the plateau come, now patient is improving, or spasticity is coming back. I think this is the history.
Yes.
So initially patient was in a shock stage. Now recovery.
Yes,
Okay.
Yes, sir.
Now, Professor Soumitra Ghosh, your comment?
So I think Professor Rai was in correct tone that it has to be concluded soon. So I think this next part, this remaining part of the story is better untold by Dr.
Let him proceed with the investigation. Proceed with the investigation.
Yes.
So proceed.
Now proceed for the investigation.
Sir, in the previous set of investigations which we received from the patient in January, all her routine blood parameters were within normal limits, except the ESR CRP values were raised to a certain extent. And the pre-existing report that we found also showed that there was a lymphocytic pleocytosis in the CSF with a raised protein count and the lower glucose levels. And there was the CBNet of the CSF was positive for MTB, where she was started on ATB. The MRI brain findings further corroborated the CSF findings, where it showed sulcal and leptomeningeal enhancement with a possible enhancing granuloma in right superior cerebellar peduncle region. Unfortunately, we did not have access to the previous plate. In our setup, again, the findings, the routine blood parameters corroborated with the previous reports that the patient had undergone outside. And the ESR reports were again a bit raised, but apart from that, the patient was not immunocompromised in any way. And the other routine blood parameters, including the CBC, LFT, urea creatinine, and sodium potassium, were within normal limits. The CSF, we repeated the CSF sample here, and it showed again a lymphocytic pleocytosis, albeit with a slightly decreased count than the previous report. but the protein levels were still elevated and the glucose levels were still decreased, but the CB-net as of now was not detected. The immunological profile of the patient was within normal limits, showing no evidence of SLE, sarcoid, or Sjogren or syphilis. So we proceeded for a neuroimaging, and because we wanted a picture of the cervical cord, we concentrated there, and it showed demyelinating lesions suggestive of demyelination in around the C3 to C5 levels of the cord. Here we have the axial section showing the contrast enhancement. So it showed hyperintensities in cervical cord from C3 to C5 levels, showing contrast enhancement, and they provided a report of a query demyelinating lesion with leptomeningeal enhancement, which was still there from previously. The MRI brain was also essentially normal, but it showed mild leptomeningeal enhancement, but it was not very much appreciable. But the report showed that there was some kind of enhancement. We further, because we suspected an optic neuropathy, we further went for a visual evoked potentials of both the eyes, and there was mildly increased P100 latencies of both the eyes when the right eye was affected more than the left eye. The chest X-ray was essentially normal. And the other investigations, we went for a sputum CB-net, which was also negative. The USG abdomen was inconclusive. The CSF for OCB showed a positive result, but it was a very non-specific finding in our case. The serum, we also suspected an NMO spectrum disorder, and we sent for an anti-aquaporin 4 and an anti-MOG antibody, which was negative. And obviously, in the present condition, we should always, irrespective of the patient involved, exclude COVID-19, which was done. So finally, where did we stand? We had a patient with cervical transverse myelitis with optic neuropathy in a patient of pre-existing meningeal tuberculosis. So after investigations, it could be either tubercular demyelination or a primary demyelination disorder. However, in considering the circumstantial evidence where the patient had a pre-existing history of tuberculosis and she was poorly compliant on ATP, and the CSA showed increased levels of protein with an increased pheocytosis, which was mainly lymphocytic. When we thought that it was likely that a tubercular etiology be kept above a primary demyelination disorder. Having said that, it is also possible that the patient can have a concurrent primary demyelination disorder, and for that we will have to keep a lookout for the patient in future and reassess the patient whether she's improving on therapy on ATD and steroids as the patient was given, and whether subsequently the patient again has a subsequent attack which cannot be connected somehow to an attack of tuberculosis, and which can possibly lead to us to a possible diagnosis of primary demyelination in the future. So we went for, we reviewed the literature that was present, and LATM, that's in tuberculosis, is a recognized, albeit a very rare phenomenon, where sir, as respectfully had already elucidated, how it is an autoimmune response to an tubercular protein. But surprisingly enough, there was also reported cases where an tubercular LATM may have been related to an NMO spectrum disorder. And some of these patients were found to have anti-aquaporin water channel protein antibodies, anti-MOG antibodies in a few patients on follow-up studies. So for now, still considering the clinical imaging results, I would still like to keep a tubercular etiology in my patient. And so the patient was continued on ATD and concurrent administration of steroids were given. Regular physiotherapy was done. Daily inspection for pressure source and water mattress was provided. And on subsequent monitoring, the patient is still in her admission, but her weakness and vision has improved from her previous status. And she is still in admission, and we are going to follow up on the patient regularly.
Thank you. Thank you.